Welcome back to a new episode of ULAT TV. My name is Álvaro Gomez. I'm a postdoctoral researcher at the Karolinska Institute, and today I have the pleasure to be joined by two real lupus experts to discuss a difficult-to-treat disease. So we have Professor Nathalie Costedoat-Chalumeau from Paris and Associate Professor Antonis Fanouriakis from Athens. So thank you very much for joining us today.
Thank you very much.
Thank you for the invitation.
Our pleasure.
So let's start with the basics. So the concept of difficult-to-treat disease has increased quite a lot in rheumatology, and I think there's probably more consensus in inflammatory arthropathies. So what is difficult-to-treat disease in the context of lupus, Antonis, and how common is this?
So you're right, it's difficult to treat disease, a very hot concept currently in rheumatology, but as you said, we're not really sure in lupus still what defines difficult to treat disease. But obviously, until we have a formal definition, I would consider it as a disease that proves refractory to at least several lines of immunosuppressive treatment. Now, we're not still certain whether there are 2 lines of treatment, 3 lines of treatment, but definitely a refractory disease to several different drugs. Now, how common it is, again, we don't have data since we don't have a formal definition. And I would suspect that this actually depends largely also on the kind of cohorts we look at. For example, whether they consist of white patients or patients that tend to have more severe phenotypes. But overall, I would guess it to be around 10 to 20% of patients.
I understand. And then if we make this definition based on drugs, then we could maybe sometimes be rushing on adding too many drugs. So then we have the practical challenge of distinguishing difficult disease or refractory disease from lack of medication adherence. So how can we distinguish those two, Nathalie? Do you have any strategies for us?
Yes, so indeed, that's very difficult. And you say 10 to 20%, it's exactly the number of patients who don't take any treatment in all the cohort, is the severely non-adherent patients. And to diagnose them, the simple way for me is to measure hydroxychloroquine levels in the blood or the serum. And when it's 0, it means they haven't taken anything, or very low levels means the same. The other way is to ask the patient, and this is, it requires some skills and some experience to do so. We can discuss about that.
Absolutely. And then if we go back to difficult to treat disease, I guess we also have this problem where many of these patients are excluded from clinical trials, at least those with severe CNS involvement or severe lupus nephritis. So what do we know how to manage this patient with difficult to treat disease, Antonis?
So if you discuss specifically CNS disease or neuropsychiatric lupus, then of course, probably this is the most, let's say, or the least well-studied aspect of the disease. So we have not learned much, but definitely, I think these are the patients that we give them the more potent therapies currently, either broadly immunosuppressive therapies or targeted therapies like B-cell depleting agents. But I think these will inevitably also be the patients that will be treated first with the new drugs that are coming, and where hopefully lupus has a big pipeline now, and hopefully these difficult to treat patients will be the first ones that will receive all these new targeted and cellular therapies.
Now let's go to the management of lack of adherence. So do you have any strategies, again, when having a talk with the patient, either with or without the measurement of hydroxychloroquine, how to address this so that we can improve medication adherence?
Okay, so first we have to understand and to be convinced that it's very normal not to take the treatment. That's the more frequent behavior, and we must stop to be judgmental and thinking the patients are kind of not crazy, but not to take the treatment. It's just very normal. Everybody has flaws, and one of the flaws might be to be not able to take the treatment. So once you are convinced about that, you can ask the patient in a better way, more productive way, and instead of saying, do you take your treatment, which will receive a positive answer because the patients want to please us and they try to behave well with us. So if we ask like that, they will say yes, and everybody will be happy, but you will have no information on adherence. Way I suggest to use is, and your treatment, can you manage to take some? And the very frequent answer is, oh, yes. And so how many times a week? 1, 2? And oh no, at least 3 or 4. And so you know they take half of the treatment. And then you can push a little bit further, saying, and sometimes do you stop for 2 or 3 months? And the answer will be, oh no, but you know, last month or the last 3 weeks, I've stopped for plenty of reasons. And then you have a diagnosis of adherence to the treatment, and more often non-adherence to the treatment. And then you can ask why by discussing with the patients and try to find solution with the patients.
Okay, wonderful. I think we can agree that this is a very fascinating topic that is evolving now from immunology and new therapies all the way through communication with the patients. So thank you very much for your insights. I think it was really good. I hope you also enjoyed online, and I hope to see you very soon in our next episode of EULAR TV.